Tiffany Champagne, who graduated from the School of Public Health, also a alum who finished 5 courses here with us at School of Biomedical Informatics. And she's a faculty candidate, and today she's going to talk about the health information exchange. So,
thank you so much for inviting me here today. And I'm going to be moving around a little bit just because that's the kinetic energy that I bring to every room. So Marcos told me that I can go as far as right here. So if I start going past, just make sure that y'all help keep me true and stay on this way. So I'm here to talk to you today about data, right? We're in the School of Biomedical Informatics. So I'm going to talk to you about data, but I'm going to talk to you about data in the context of healthcare, and specifically in the context of health information exchange. I'm going to share with you a little bit about my background, a little bit about my interests, talk to you specifically about some research that I've done germane to health information exchange. I'm going to take you through a fun, exciting little use case that we're doing right now every day using 1987 technology, and I'm going to wrap it up with a bow at the end, okay? And I promise to keep you awake. So thanks for the full house too, by the way. This is great. I love to see that. So this is a little bit about my background. I'm originally a registered and licensed dietitian. I have about 10 years of experience working in a clinical setting. I have a master's degree in business administration with a focus on finance. So every time I look at a problem in healthcare, I look at numbers. I see numbers, I see spreadsheets. I think about, what is this going to cost us? How much is this going to save us? What kind of time are we going to save? How is this going to save us in terms of minutes, in terms of seconds, in terms of dollars? I think about numbers in that way. So that's the first introduction to data and the way that I think about everything in terms of ROI, or return on investment. I have about 10 years teaching college students, so I love being in front of a class. I love working with college students, and I love, love, love to teach. My PhD is from the School of Public Health. I am the second student that ever petitioned to take courses here at the School of Biomedical Informatics, and I fought to get those courses to count, and now students can freely take classes back and forth, and I completely claim credit for a lot of that. Whether or not it's true, I completely claim credit. And I have spent the last 4 years of my career as one of the founding executives with the Regional Health Information Exchange here in Houston. And Dr. Jim Langabeer was our founding CEO here. And now he's here with you. You get the pleasure to have him here at the school. So the organization of the presentation is going to be such. We're going to go over some basic definitions. So for those of you who don't have a healthcare background, I want to take you through a little bit of healthcare finance and why we don't finance things in a way that's tenable in the United States, and just kind of make the case why we have to do better. And when you are out there, or you're out there right now, but when you're out there after your degree, why it's so important to think about cost, and why it's so important to never lose sight that there is a patient that you are working towards in any kind of setting. Whatever kind of data you're doing, if you're doing genetics, if you're doing any kind of EHR technology, there is a patient that you're doing this for the benefit of, and it's all in the context of that patient. We're going to talk about the public health significance of the research. We'll look at some models of health information exchange nationally, and that's from my published research. We're going to look at that nifty little use case that's going to leverage some 1987 technology, and I'll just make some recommendations for future research.
Get out real quick. We lost audio.
Okay. Moving around too much.
Sorry about that.
No problem. I was what? I was muted. Yeah, I was probably muted. Yeah, that's okay. I'm going to start over. So is that okay? No. Okay, good. All right, so moving on. So healthcare finance 101. We spend way too much money in the United States. If you have been a member of a healthcare system in another country, welcome to the United States, where we will spend more money on you than any other country in the world. Any other country in the world, with not necessarily the best outcomes. When you need a hammer, we will use a bulldozer every single time. every single time. We do have amazing healthcare outcomes, amazing. I mean, you can walk across the street to MD Anderson and miracles are made. You can go across the street to Texas Children's Hospital. Pick a hospital, miracles happen, but we spend a tremendous amount of money in this country on healthcare. Almost twice as much as the next industrialized country, which, if you're curious, is in Scandinavia and in England. So we spend the greatest amount per capita, per person, of any industrialized country. Nearly $8,500 per person. We are on, did I lose audio again? I'm getting beeps up here. No? Okay. So we are on track to spend around a quarter of our gross domestic product. That means what we make in the United States, all the money that we make, a quarter of it goes towards healthcare. That is nearly twice as much as any other industrialized country. I don't know if that weightiness kind of sits on you, but we spend way too much with not the same outcomes as any other country. So where is all this money going? Okay, it's going towards technology. It's going to what we're doing right now. So how can we deploy this technology the most efficiently and in the best way that we possibly can for the best outcomes? That's where we all come in. Just an interesting fact, do you know which state does the absolute worst in insuring people for health insurance? Yes! Texas! Guess which county does the worst? We're sitting right in the middle of it right now. Largest percentage of uninsured in the country, right here in this zip code. You're sitting in it right now. We're living in it. So this is the gaps in transitions of care, okay? So a typical patient in this country, you're being coordinated by multiple doctors. So if you think about it, you think about how many doctors you might have. If you have a chronic disease, let's say you have diabetes, treated fine, no problems. You may have an endocrinologist. You may have an eye doctor. You may have a specialist, a podiatrist that you go to see for your feet. You may have a general practitioner. If you're also a woman, you may have an OB-GYN. That's 5 doctors right there, and that's if everything's perfect, okay? If you get into an accident, you're going to go to an ED. You'll have an emergency physician. Are they going to be able to get all your records? What about if you have any kind of behavioral health? Maybe you have a psychiatrist that follows you. Now we're up to 7. This is still someone who's in pretty good health, okay? This is not someone who has really challenging problems. This is someone who's of average, pretty good health. You're responsible for coordinating your own care as a patient in this country. You don't have someone that's coordinating care for you. You're seeing these providers that are belonging to different delivery systems. They all have their own electronic health record technology that don't all necessarily talk to each other. So how are these records going back and forth? How are people coordinating your care? How are they not duplicating things that have been done over and over and over again? This can get really complicated in the case of a very sick patient, or a child, or your mom, or your dad, or your grandparents that have to get stuck over and over and over again. Haven't I already had that lab test? Why are you doing this again? Why am I having to pay for this again? Is my insurance going to cover this? These are the kinds of questions that we get asked in healthcare management. So there's abundant research that shows this, abundant research that there's gaps in care. And again, we're in technology. We're in the data business. We see this. We know. There's solutions that we can come up with. There's solutions we're working on. There's solutions that we can put in place to fix this. New England Journal of Medicine states 16 physicians coordinating care for chronic conditions. 16 physicians, many of them in different types of systems. These aren't people that are all under the same roof. Medicare patients, between 40 to 70% admitted to the hospital received services from a mean of 10 or more physicians during their stay. This is one episode of care seeing 10 or more physicians that are probably not talking to each other. Maybe even in the same chart and in the same electronic health record system and not coordinating care with each other. This is a problem from a safety aspect. This is a huge problem. The AHRQ reports that routinely, almost 50% of patients fall through the cracks in transitions of care. 1 in 5 discharged patients may have an adverse event within 3 weeks from missing information that should have been given to them at their discharge. This is simple. This could have been, Dr. Smith, you're going to be discharged now. You just had surgery. You need to follow up with your doctor in 3 days. Maybe her nurse doesn't communicate that to her. Maybe she was on medication when she was discharged, so she didn't understand it. Her husband picked her up, and she was like, I don't know what they said to me. I don't know what that was, and we lost that piece of paper. So she never scheduled a visit. Nobody ever called her to check on her. So she has an adverse event. Very simple stuff, but no one is coordinating this care. So in comes collaborative technology. Collaborative technology, that seems kind of complicated. I don't really know what that is. Is anybody scratching their head? What's collaborative technology? I don't even know what that is. You know what this is. This is collaborative technology. So let's look at how many of you know what this is. Anybody use Outlook? 1.1 billion of you use Outlook to schedule meetings, to schedule events. Okay, do you want to come to this meeting? I'm inviting you to this meeting. You're collaborating with people. This is Outlook, okay? 1.1 million. What about billion? Sorry, what about Twitter in the middle? 500 million people collaborating. This is collaborative technology. eHarmony. When we started the HIE, Dr. Langebeer and I would go into meetings and say, it's like Match.com. Come on, people, you got to join, because if everyone doesn't participate, you're only going in. It's like Match.com, and you see yourself. You don't want to just see yourself. You've got to collaborate with other hospitals to come in. eHarmony, 1.2 million users a month get on eHarmony to find the love of their life and collaborate. 1.2 million souls a month. Facebook. Don't even get me started on Facebook. 750 million active users. And if someone knows this, I want them to raise their hand. Does anybody know what this is? Come on, students. This is one of the largest Chinese dating websites out there. Nobody knows it? Come on, I was hoping someone would recognize this. No one knows what it is? Over 1 million users monthly? China Love Cupid? Come on. I was just hoping I would get at least one smile. I was hoping I'd get one smile out of that. This is collaboration technology, though. It's technology that bridges the gaps where people come together so they can share information around a common goal. So what would this look like in healthcare? Who's our common goal? Remember at the beginning talking about data, it's not always just about the data. Who's at the end of the data? It's the patient. The common goal in healthcare technology is all about the patient. So if we think of the patient as the nexus here of care, you may have a clinic. Clinic has electronic health record technology, right? So maybe they're using eClinicalWorks. They're loading all their charts into eClinicalWorks, Allscripts, Greenway, Aprima, any of these. Maybe you've worked with these. Maybe you've learned about these here in your classes. Maybe you have a solo doc, a solo practitioner, a physician out in the field. Maybe this is a freestanding ER. You know, when you get the flu on the weekends and you need to go somewhere. This person also is using electronic health record technology. These may not be talking to each other. You see them during the day, you see them on the weekends. Might be useful for them to talk to each other about you. Same with this one. Same with this one. This one may be at a hospital. This may be big technology. Epic, Cerner, big time technology. What the big players in the TNC use and what the hospitals use. Big time technology, massive databases of technology, massive units of what we can mine to see. What kind of diseases are we seeing? What are our treatment rates? What are our success rates? How many congestive heart failure patients do we have right now? This kind of centralized data repository information that anybody would love to get their hands on. This is the patient that sits in the middle. Health information exchange can bridge the gaps between all of these. Health information exchange using standards, HL7, a little bit of HL7, a little bit of CCDA, a little bit of CCD, a couple of different standards that are coming out, can be the pipes that go from one electronic health record system to another electronic health record system. Matching patients, using record locator services, providing patient information at the point of care for physicians that are treating patients. That's the cool stuff that I'm interested in. So services that can typically be provided by health information exchanges are clinical integration. So if you're at MD Anderson, you're seeing patients from all over Houston, all over Texas, all over the country, all over the world. You need the ability to pull those records, patient records that may exist in other places, right? So you want to get the patient's history and bring it into your electronic health record. So MD Anderson is converting over to an Epic system, an extremely robust electronic health record system. This system will be able to talk to other systems, not just Epics, but using health information technology, interoperability systems, using different kinds of standards with clinical integration, we'll be able to pull records in so you can know a history. You can know any kind of allergies. You can know prior treatments. You can know everything about that patient that you need to know at the point of care when you're about to deliver chemo, radiation. I don't want to repeat any kind of test maybe that they've already had, anything like that, without having to leave their Epic system. This is clinical integration. Medical image exchange. I mentioned how healthcare finance is really not viable in the United States. We repeat so much. We repeat MRIs, we repeat CAT scans, we repeat tons of radiological exams that don't always have to be repeated. They're a danger to the patient. They can be a danger to the pocketbook. They're not always reimbursed by insurance. They're not always reimbursed by the patient. Who ends up paying for that? Who ends up paying for that? Taxpayers do, absolutely. Healthcare costs go up as a result for everyone when it's uncompensated. No one wins. No one wins in this case when things are not reimbursed and duplicated over and over and over again. If you could just get those prior studies, get a prior study, view it. If it's good enough, if it's excellent, wonderful. The patient doesn't need to go through any additional radiation. Is that something?
No.
Medical image exchange. Secure direct messaging. This is just a way to give physicians and clinicians the ability to send messages back and forth in a HIPAA-compliant environment. A lot of times we're seeing physicians and other clinicians and nurses and social workers and people that are maybe ancillary providers, like social workers, or other people that don't exist and live in the hospitals, that they're just being sent emails about patients. They're being sent charts about patients to their Gmail, to their Yahoo Mail, to their Hotmail. This is not HIPAA compliant. You can't send PHI through, you can't send protected health information about a patient that's through a non-protected way. So these are all opportunities for us to send data and for us to be able to collaborate and to know how to collaborate around a patient. So these are some more formal definitions of health information exchange. The one that I really like is the one that's out of HIMSS. This is technology that facilitates the exchange of patient-specific electronic health information. It's no more fancy than that. You're just taking patient health information from one place and you're moving it to another. There's a lot of other stuff you have to think about. Technology, standards, patient authorization, legal rights, signing contracts, who gets money, do people get paid for it, and we'll go over some of those barriers. Basically, this is all that it is. The benefits are huge if you can make this all work. So, I just want to drill the significance of this all. It's not just about saving money, but our public health benefits when the outcomes increase and the cost decreases. If outcomes are better, that's good for everybody. Everybody wins. Cost decreases, everybody wins. Outcomes increase, patients happy, things aren't duplicated, everybody wins. Care is provided, is at a higher level, everybody wins. So it's important to understand, and I became very, very interested in doing my dissertation to see, not very many people have studied if collaboration technology is what is it really doing? How is it evolving? What are the standards? Who's doing it out there? What are these models that exist that are out there? And so I looked, and at the time, in 2013, there were 206 HIEs that existed, public HIEs that existed across the country. And I studied every single one of them to look at their models, to look at how they developed, to look at their method of funding, to look at their technology and their architecture. So I'll give you a little bit of an idea of some research that I published based upon this. So I pulled out 25 of the HIEs from the largest metropolitan cities, basically ones that compared to Houston, since I was working in Houston, living and breathing the HIE in Houston. So large metropolitan community-based not-for-profit HIEs, which was very important. I wanted to focus on not-for-profit HIEs because as a neutral entity, they are slightly different than enterprise for-profit HIEs. And I collected qualitative data, and I broke it out into a framework, basically looking at the scale, what size that they covered. Were they small HIEs? And I found that a lot of so-called HIEs were really just websites that existed that were maybe one hospital that had just a few transactions. So I wanted large HIEs that covered 20 counties, several million people that were really exchanging data in a meaningful way to see what were they doing and how were they doing it. So these are the locations of the 25 which I looked at for basically geographic sampling. So the top case study is, of course, on Greater Houston Health Connect, and then the two most successful in my research, Healthbridge in Cincinnati and then Regenstrief in Indiana. And Health Connect covers around 7 million people, Healthbridge in Cincinnati covers 3 million, and Regenstrief covers around 7 million. And what I found was interesting was that, unlike in Houston, most health information exchanges don't even give the patient the option to say, yes, I want to participate in this and I want to share my data. The patient participates. The patient isn't asked. So that's what we call an opt-in model. So here in Houston, if you visit a hospital, you will be asked to sign a consent form because the hospitals in Houston and in the 20 surrounding counties participate in Health Connect. That's called an opt-in model. This is a make or break scenario for most health information exchanges. So as a patient, you say, yes, I want to participate. I want my information to be shared with doctors who treat me. That's important to me. I want them to have information on me. I don't see why I wouldn't want that to be shared. Yes. So your information is shared freely. These other two don't even ask. Your information is just shared, which they can do by law. Our hospitals didn't want that. There are also different technical models. Centralized data repository, Regenstrief, puts everything into a giant data repository, mines it, does all kind of neat, nifty things to it. We don't do that here in Houston. We use what's called a federated or a decentralized type model. It's kind of like Expedia.com, if you will. So Expedia, right? Y'all got my analogy back there, I can see already. So Expedia doesn't duplicate the entire database of United Airlines or Continental or Southwest or Air France, right? They say, where do you want to go? When do you want to go? How many people are going? So that's what you do with a decentralized or a federated type HIE. Dr. Angela Ross is my patient. This is her age. This is her medical record number. Are there any other records that exist for Dr. Angela Ross? Health Information Exchange goes out, queries, and brings back. There are 6 records that exist from various hospitals that she's been seeing, and it brings them up. Query and retrieve. So I also found that there are 5 factors that determine the success. Meaningful use is huge. Thank you to the government. Meaningful use, some of you may be working in meaningful use projects, but meaningful use, which states that physicians have to adopt EHRs if they're going to accept money from the federal government. By a certain point, they have to do certain things with it. They have to use it in a meaningful way to exchange data with other providers. They have to step it up each year. Each year it gets a little bit more difficult. HIE, Health Information Exchange, is a factor in meaningful use. Eventually, everyone is going to have to exchange data in a meaningful way. They're going to have to utilize this technology in some meaningful way because it is helping the patient drive clinical outcomes. So that's definitely help. Changes in insurance reimbursement. Insurance companies no longer are paying for doctors to order, I want this test run again, 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 I want this test run again. Insurance companies are saying, this test has already been run. You need to go find where it's been run, and you need to bring it into your practice. We've already paid for this test. It was done yesterday across the street. Go and get it, or tell the patient to go and get it. If you're a patient, if you've had a CAT scan, and you go and you say, I want a second opinion, I think I want that CAT scan done again, guess what? You're going to have to pay for it out of your pocket if you can get anybody to do it for you, because your insurance company will not pay for it. They're not going to pay for it, and they're very, very expensive, so you're not going to do it the second time. So those have helped encourage HIE usage. Most importantly, hurdles that I find regularly. So technology, so when trying to bring this technology to any company and trying to any hospital and trying to say, you know what, health information exchange is a great thing, Dr. Yang, and I really think that you need to bring this onto your hospital. You know, MD Anderson should really have health information technology because it would be a really great thing. Okay, Dr. Yang, if he's the head of MD Anderson's technology, if he's the CIO, if he's anyone else, he's going to say, okay, I have a few questions. Some of them are technical. How are you going to share our data? Who are you going to share the data with? Do I own it? Do I own the data? What if I decide to pull the data back? Can I do that? Because that's always a question. So some of the questions, yes, they're going to be technical. And as data experts, you know they're going to be technical. Some are going to be financial. So that's why we're getting into the yellow here. Some are going to be financial. How much is this going to cost me? Is it going to be expensive? How much time am I going to have to put my IT staff onto this? How much time is it going to take them? Am I going to have to pull them away from other projects? What kind of labor am I talking about? Are you sustainable? What about if you go out of business? Then what am I going to be left with? That's also a question. The big thing, though, and the really big thing that's hard to convey is organizational. Who else is in this? Is this going to make me more competitive? Somebody else going to try and steal this from me? Right, Dr. Murphy? Right? Who else is going to participate in this? What types of entities? Are you going to take my data and sell it to life insurance companies? Are you going to take my data and sell it to a pharmaceutical company? Are you going to take my data and sell it to the hospital across the street so they know my trade secrets? Now I'm worried about this. So, what's really important that I want to convey is in health information technology in general, it is about the technology, true. It's about data, and it's very, very important that we understand data. We understand jargon. We understand how it works. We understand how it can benefit the patient, especially in healthcare. We understand the finances. What are the implications? How much is it going to cost? Is there a return on the investment? What's the labor that's going to be required? But organizationally, you have to understand. If you are going to make the case to a CIO, or if you are the CIO and a case is being made to you, you have to understand the implications of the competition and of the space and of the management that's involved when making a huge decision. Whether it's choosing a new technology to go into your hospital or your clinic, or you're selling a new technology that's going to a hospital or a clinic, you have to understand the organizational landscape. So, summary of those findings, basically, federal policies have definitely helped. They always help us with health information technology. Help us inch forward with meaningful use, help us drive adoption, because if we leave it up to people in healthcare, We are so far behind. It is not slick and savvy like Apple or Google. I mean, you can look into technology, and in healthcare, we are just dramatically behind in so many things that we do. So federal policies have helped inch people along. Even though we think it's important here in Houston with our HIE to give patients the opportunity to say, yes, I want to participate, most people across the country don't share that view. And so they have had an opt-out security model. 64% of most health information exchanges don't even ask the patient, unless the patient says, I heard that you're sharing my data with people, and I really don't like that. Oh, okay, that's fine. You don't like that, then we'll take your name off the list. But otherwise, your data is in. That's an opt-out model. Most everyone uses a third-party vendor. That means they go out and they buy technology to do this. They don't customize or don't make their own types of solutions. And scalability, size is important. You've got to cover a large area of patients for this really to be important. So this is kind of that Match.com effect. The more people that collaborate, the better. The more that collaborate, the better. So just to reiterate on the focal points of what should be important for any collaborative technology. Fragmented care creates problems, especially for people that are uninsured, people who are medically indigent. So you're maybe not indigent, but you're medically indigent, which means you don't have health care insurance. You don't have good coverage. You maybe don't have enough money to pay for your health care. What that means is it becomes everyone else's problem. And it becomes everyone else's financial burden. Because if you're not paying for your health care, everyone else who does have health care insurance is paying for your health care. So it is our problem. It's everyone's problem. Everyone who receives health care. So our primary focus is always on improving quality access, reducing costs, and increasing patient safety. That should always be our primary focus in healthcare. And health information technology that can bridge these gaps can solve all of the problems. Ready for the fun use case? Yeah. Okay. So most of the students in the back, this is all going to be for you because all the professors in the front are going to know the answers. Okay. So what do you see? HL7. Come on. The professors already beat you to it. Okay. So HL7, right? So HL7 was developed in, I already told you, 1987. Awesome. So it's now 2015. Okay. Right. Good. So we're rolling here. So HL7, right? So it kind of just, if you've never seen HL7, it kind of just looks like a lot of lines and letters and everything. We get super psyched when we see this kind of stuff, right? If you've never had an HL7 class, Dr. Smith is like, this is so cool. I'm really loving this presentation now. Okay. So this is ADT, admission, discharge, transfer. Okay? Stick with me here, because I'm going to break this down and everybody's going to know what an ADT message is. Every time you go to the hospital, an event is created. An HL7 event is created. An ADT message. Admission, A. Discharge, D. Transfer, yes. So we got a winner in the front row. Okay, ADT. So Health Connect and virtually all health information exchanges have real-time HL7 connections. HL7 is like chatter. It's constant. It's chatter. It's not episodic. It's chatter. It goes on constantly. Every time someone comes into the hospital, admission, every time they leave, discharge, every time they're escalated to a new level of care or moved in the hospital. So maybe what does that look like practically? So I was doing okay, I'm in the hospital, now I'm not doing so okay, I moved to the ICU, intensive care unit. Not good. That's a transfer. An ADT message is communicated, okay? Chatter, this is sent out back and forth. Got it? So there's different components. Those are really useful. Within these components, there's different types, okay? Different segments. So we've got an EV in, right? Event type. This tells me kind of what's happening. We've got the patient identifiers. So here's where it starts to get good. We know the name, we know date of birth, we know race, gender. Stuff we can match on. We can match patients this way. This is how we start to know that one patient over here is the same patient over here, is the same patient over here, is the same patient over here. This is the good stuff. This is how we match across locations. Then we've got a PV1 segment, patient visit. Did they come through the emergency room? That's really important. How did they get in this hospital? Was it an emergency visit or was it not? If you're an insurance company, if you're a primary care physician, you want to know, how did my patient get in the hospital? How come I didn't know about this? I didn't admit them. Oh, they came in through the emergency room. Oh, okay. I see. I got it. That makes sense. Who's the attending physician? Very good stuff. Insurance information. Are we going to get paid, and how are we going to get paid? Right. Really good stuff. Okay, so let's look at this again. So now, are you starting to see some patterns? Sure. You starting to see some of that? Awesome. So if you didn't see it before, maybe now you're seeing some of this. So boom, now what I've got, I know that somebody came into Ben's Hob. I know that it's a hospital. A01, it's an admission. I know that now. The event type, they came in through the emergency room. I know that.
And that's the date, right? Before.
Who's my patient? Betty Firefox, right? Some other stuff, we know where she lives, we know her next of kin, we know some other stuff, but I'm just highlighting the big things, cool things. Dr. Gonzalez, that's her attending physician. Important to know. She's got an allergy. That's really good. This is what it does to her. It gives her hives. What does she come in for? Preeclampsia. She's pregnant and having problems. This is huge stuff to an insurance company. Big time. And her insurance, Texas Health Plan, I made something up. So what can we do with this? Knowing this information that's constantly coming in, we can start routing this information. It's coming in instantly, as soon as it happens, as soon as a person comes in. So who can I tell? Who may want to know about this? Insurance company may want to know. Uh-oh, somebody came in. What happened to her? Who else might want to know? Her PCP might want to know. Her primary care physician, her OB-GYN might want to know. If the OB-GYN's listed, we can tell the OB-GYN immediately. Somebody else might want to know. We can start routing this back and forth. We can let people know immediately something is going on, because I'm going to tell you something. Everything that happens in the ER is off the grid until it's processed by insurance. 24 hours to 7 days to sometimes 30 days later. None of these people would know about it. Depending on where you are, it could be 30 days later before anybody would ever know that this happened to this woman. If we can get on it ahead of time, she can be processed. As soon as she leaves, another segment is going to be created. So we know, follow up with Miss Betty Firefox. She needs to go into her OB-GYN and see what was happening so we can keep her out of the hospital. So, that was your ADT lesson. Did everybody get that, by the way? It's pretty simple, right?
They'll get more of it in 5300.
You'll get more of it in 5300, says Dr. Smith. So, data sharing is hard. This stuff is really, really hard. What you're doing, what you're learning, what you'll eventually end up doing, this stuff is hard. And it's not just about the technology. It's not just about the data. It's what we do with it. It's in the context of how you're going to do it. If you're working with patients, it's in the context of there's a patient at the end of this. What does that mean? If you're a CIO, or if you're talking to a CIO, it's also in the context of the slide that I showed you with the finances. It's good to understand and to know about that, and to understand how much does this cost? How much is it going to save? What's the time factor going to be? It's also important to know in the larger scheme of things of the organization. What's the competitive aspect look like? Why am I getting resistance? Why are people not wanting to do this? Is there competitive aspect to this at all? Or is that something that I can use to my benefit that can actually help people want to do this? But this stuff is hard. And to decide how to share, what to share, how much not to share, that's really tough stuff to figure out. So, in summation, I think that this type of collaborative technology that can sit between healthcare providers is essential. I think it's very, very important. I think it's dramatically understudied. I think it's something that needs more of a focus, We've got institutions that have spent billions, with a B, billions of dollars developing their technology infrastructure, but then it stops at the silos of their four walls. So all of this information about their patients may not leave, but the patients do. So we need some type of collaboration technology that extends and travels with the patient, because we are all patients. If you're not a patient today, you will be a patient at some time, hopefully in a good way. Hopefully it's delivering a baby or something wonderful like that. But academic studies, and in the context of an academic environment, studying this, working on this, learning about this, working in this environment can really help guide policies, decisions, and implementations in the right direction on how we do this and how we implement collaboration technology in the best way. I also think that there's room for longitudinal assessments of HIEs and what's the true value from a financial perspective and then also from a clinical perspective. Are they really making an impact? And if not, why not? And how can we put that back on the right track? And I believe that, basically that's my last slide. Because I think that, once again, if I haven't drilled into your heads about how important cost is, I'm just going to say it again, that driving down cost is very important. And that in the context, management, policy, and leadership, so very, very important in a data-driven environment. And that is my final slide. So I'll entertain questions. Thank you, Dr. Yang.
Yes. You made a strong point of the cost avoidance of duplicative tests as a driver for a lot of this. Now, this is a good lecture, but we spent millions of dollars with high tech and haven't seen a lot of good results. So talk to me a little bit about the knowledge that the clinician is missing, because that's really at the heart of the problem is that if I'm going to operate on somebody and information is not readily available to me, I have to do something. I either have to order, test, evaluate, because we're going to take that patient to the OR regardless of whether we have information or not.
Right.
So what's the cost of not having the information? I'm talking about health information management, not just mere the avoidance of a test. So are there any studies that have actually quantified what is the cost of mismanagement of information?
So it's difficult to measure what's not there. What's easier to measure is the duplication aspect. So it's kind of like measuring when someone didn't die. It's easier to measure when someone did die. It's kind of like a mortality study, if you will, and it kind of philosophically. So there is a bevy of research that's coming out now that's saying duplication of test, when it's unnecessary, when the test is already there, that if you duplicate the test, that is costing money. Now, what you're asking is a slightly different question, which I think is very, very interesting, and it would be something that could be explored. Yeah, it's just trying to structure how would that cost avoidance be. But what we're seeing now is the Brookings Institute just actually released a study, and it was actually published in the last AMIA. So it was the very last one that I think came out maybe in June or just in July. So, and it was a single author, the gentleman from the Brookings Institute, and I can't remember his name off the top of my head. But he was saying that in Western New York, that if the physician was querying the HIE in Western New York, where they have 100% penetration, so all hospitals are feeding into the HIE. So there is information there. So what you're saying is there's not information there. But when there is information there is a nearly 50% reduction in duplication of test. So there's a huge proof for the reduction side. Now what you're asking, of course, is the other side, which is a different question.
HIEs are not free, so the cost benefit of infrastructure versus the cost avoidance is still a question.
Right, but what you can look at is how many times you're not getting reimbursed from your insurance companies for duplication, because that is a concrete line item on every single hospital's budget. So you have I'm not getting reimbursed, and the reimbursement, the lack of reimbursement rate varies, but it could be anywhere between 10% to 20% for duplication of tests. So if you're not getting that back on your line item, so every CT scan could be between $1,000 and $1,500. So if you're not getting that back in 10 to 20% of the cases, it can get pretty high really quickly. If you were to invest $100,000 in an HIE over the course of a year, the ROI is easily made.
So whenever I reflect on this or hear such a dynamic talk about the benefits of the HIE, it seems quite self-evident of what could happen with the sharing of technologies and information. But as you mentioned into the evolution, I was wondering if you want to talk a little bit about where does the patient aspect of this come? Again, I think one of the consequences of meaningful use was providers owned the patient portal and were required to give up patient portals as a doctor. In some way, I didn't realize that most patients have more than one doctor. So I, for instance, have seven patient portals with my various physicians that I've used over the last 3 or 4 years. So the telephone-information exchange, how does that also evolve into the patient portal and empowerment? Because I just want one portal for myself.
Yeah.
The 7 facilities and physicians that I use, I want them to sort of bring this information together for me as a patient to control it. I've heard a little bit about Commonwealth, but any comments you have about the patient empowerment component?
Yes. So as of right now, across the country, we haven't seen a lot of HIEs do this successfully. And because it is complicated, back to my data sharing is hard piece, but what you're saying is echoed everywhere, because there are portals that, patients have the Epic portal, we've got this portal, we've got this portal. Everybody has the same thing. You don't want the same one. So it would be an HIE that's patient-facing, basically, is what you're talking about. No one has done this successfully because the authentication piece and the whole encryption piece, and because it is utilized, you have to be on the EHR to use it. And because the patients aren't on an EHR, and it's not an EHR type system, this type of technology hasn't successfully been brought down in mass from multiple providers to a mobile app, if you will, that's successful. People have done it and tried it, but I don't think any of them have been successful to the ends that we would deploy it here in Houston. Across the providers that we've got across the street, no one would implement that.
And just have a comment
Of course.
Also, it's an organizational issue because here in Houston and across everywhere else, even if the technology can do it, which we can find technology that will aggregate, pull from all of you the same exact thing presented. If I'm Baylor or I'm St. Luke's, the thing I want is my patient stickiness to my system. You log into my Epic system. I'm logging into some other thing where you've drugged me across from the brand, the system that I want them to be attached to. So we had this conversation with a number of people. What if we ping, query, pull back into a portal? And we talked about this 2-3 years ago here in Houston.
Mm-hmm.
There was so much organizational resistance to that. For that reason, we're going to lose our patients. So I think what has to happen is the system has to use an HIE to pull back all the data available, pull it back into a Baylor Epic or an MD Anderson clinic station until Epic's up and running or wherever, but they have to do it. Because that was the kind of talks we got into.
Yeah.
That's the answer I want to hear.
Yeah, I know, but it would have to go the other
The
direction.
individual patient is powerless here.
Yep.
True.
That's
That's
right.
what's unfortunate.
And it
because-
seems to me in your presentation, you got a slide where the patient was in the center.
Yep.
But in truth, the patient is not the center. The center is the hospital. And the owner of the data, which I've always said should not be a hospital, it's your data. It belongs to you as an individual.
Yeah.
And should go
I agree.
with you wherever you go. And
Yeah.
that's the fallacy to me of this
Yeah.
even meaningful use had no piece of where the patient belongs in this picture. It's ancillary.
So I guess I would propose for our students, this is your opportunity to come up with a killer app.
Yep.
No,
That's right.
I'm 100% serious. So what I'm thinking about is I'm thinking of things, so I'm just moving into taking care of my older parents who have multiple physicians. How do I aggregate their data? Not just their healthcare data, but their social security data or other things like that. So, and your audience is the patient. It's, you know, if you can get enough people on board, and if you can build the interfaces correctly, HL7, to bring in the data from the different organizations.
But wasn't that what Blue Button was supposed to be?
It's the killer app.
Yeah.
But Blue Button's not commercial. You need the business behind it. You need the profits,
Yeah.
you need the reinvestment, you need the, so there is something out there called Blue Button that was initially fielded by the
VA.
Veterans Health Administration that's now been adapted for use by HHS and CMS. It's something you guys can learn about. But I'm just saying, this is an opportunity. That's the way you need to be looking at it. This discussion we're having up here, one of you could be the next,
These are problems
what's his
that
name,
need
Zuckerman.
solution.
Right.
That's right.
Right.
And when you were talking about the organizational part, so what's gonna make the organizations happy? What are they saying that, get away from me? What's their biggest thing that you saw?
So in thinking about the models, so what makes our community happy is you're not making a centralized data repository of all my data. We have the top research institutions in the world here on Fannin and on Maine. They do not want MD Anderson, Texas Children's, and everyone else along the row, Memorial Hermann, everyone else, they do not want you duplicating their entire database and putting it into a SBMI-sized database, okay, of a 10-story building. They do not want their information collated together with everyone else's. So this decentralized type of approach is the only thing that made everyone happy and will make everyone happy today for this region.
Can I, this may be a little bit off topic, but following up on all the, can you speak to the current status of the accuracy of the patient matching algorithms that are being used? Because in the work that I've seen with master patient indexes, they are not infallible.
No, they're
So
not.
you wind up
Right.
with some patients being mismatched onto a patient, and conversely, you wind up with an incomplete record in some cases. So what's the current status of the accuracy of probabilistic matching?
So probabilistic matching is, you know, I mean, I hate to use the phrase, it's complicated again, but it's kind of a junk in, junk out type thing. So any kind of interoperability solution that's matching across multiple systems relies on the quality of data inherent in those native systems. So if I put in at my clinic Maria S. Vasquez and someone else puts in Maria Vasquez, then my matching algorithm is going to be knocked off. Or if I spell Vasquez with an S instead of with a Z, my algorithm is going to be knocked off because that heavy reliance is upon first name, last name. I mean, gender, date of birth, of course, but if 16 points in a matching algorithm, if you've got heavy reliance on first name, last name, you're still going to get points off for your matching algorithm. So what we like to do with our algorithm, and I can only speak to the one that we use at Health Connect, is we defer on the side of we don't merge anything. So everything gets returned back. And the physician or the clinician or whoever's selecting the patient is left to say, is my Maria Vasquez the one that lives on Live Oak, or is my Maria Vasquez the one that lives on West Elm? And make that final determination and then proceed next into the next layer. But there's one step back. If you're looking from your native system, it's going to match on your medical record number as well. So that's a really strong match, unless you've got a lot of junk in your own medical record. So it's kind of a quality of data at your native system.
So that matches what I was just asking about the organizational piece, then it has to be matched together.
There's a lot of
They're not gonna
duplicates.
want it-
There's a
but
lot
then
of
the provider's
duplicates.
gonna say, why you put
Yes.
that on me to decide which one of these is the correct one?
Well,
Because it takes a human.
yeah.
Another question. So, I once asked a CEO of a company that does medical transcriptions about the potential of health information exchange as a viable source of revenue, and he said that these HIEs had to be nonprofits, that there are legal restrictions on selling and the exchange of PHI.
So what I found, so my research is primarily on community-based, not-for-profit HIEs. So that's in line exactly with what you're saying. And the question for anybody, I guess, who's listening was, there are certain restrictions surrounding not-for-profit HIEs and selling data and PHI to outside entities. It doesn't mean that those entities don't ask. And it doesn't mean that those entities don't continue to ask and ask in different and creative ways, because they do.
Right, and just to be clear for all the students, it is against the law both federally and in the state of Texas to sell individually identifiable data for profit. So that's just to,
Right.
if you were wondering when they're talking about the selling of the data, it's against the law.
But they do ask us even to de-identify it, and we don't do that either. Identifiable or de-identified.
So I just wanted to make a quick comment actually about the costing question, because cost comes up a lot, and it's something I spend a lot of time on across the street. And so to your question, there's a more fundamental problem that we have in healthcare here in the U.S. and issues, and that is the fact that we really don't know what an episode costs, because most hospitals go based on charges and billing, and it's been done that way for so long that it's included guys think that the resources that are actually spent to deliver care. So we spend a lot of time hearing people talk about technology and costs, and I spend a lot of time listening to cost discussions where you added it all up. The hospital is making money without doing anything. It's just not possible. So we're actually spending a lot of time in the Anderson really trying to understand what it costs at the patient level for an episode, and it is slow going. So the answer to your question is extremely difficult. Even if we wanted to answer, nobody understands the basic cost.
Did you have a question over here?
It sounds like the patient doesn't own their own data, or the institutions own the individual data on sets and.
So the question was, it sounds like the patient doesn't own their own data. So technically, it is your data. The problem is that you do own your own data, but the problem is sometimes it's difficult to get your data. Does that make sense? Good luck getting your medical record. You are entitled to it. You can have a full copy by law to get your entire medical record. However, there's an administrative process that you would need to go through in order for you to get it, and there may actually be a cost for you to get your medical record as well.
These individual organizations all hold data on patients. Does each organization own that data? Where's the data ownership? Where does that sit?
That's a more complicated discussion that I would be glad to take up with you afterwards, actually. Yes.
I have a follow-up question to Susan. Okay, as a pioneer of the duty group program, do you have any words that you want to share with the future duty group student here, and think also the opportunities regarding HIE for the future implementation?
Yes, absolutely. So it's not just about the technology. I realize some of you come from a straight technology background. You're learning about healthcare. Some of you may come from a straight healthcare background and you're learning about technology. I know one for sure. He's been working with us. So it's really important to understand both components. If you're coming directly from a technology background, it's very important to learn about the context in which you will be working. So if that's in a hospital environment, or you do hope to work in a clinic or a healthcare environment, it's very important for you to get some exposure to that environment. To get some exposure either by volunteering, by visiting. There's always, always, always ways for you to get into a healthcare type environment, for you to see what that actually looks like. Because it's very, very important for you to see the kind of setting that you will be wanting to work in. And the challenges are different, and it's good for you to understand the whole breadth and what's expected of you, because it's not just about the technology. It's very important to learn about the data that you'll use. Yes.
Final question. Okay, once again, let's thank Dr. Tiffany.
Thank you so much.